Good evening, everyone. I am Dr. Zeyad Fadl, Senior Radiologist in Al Jahra Hospital. I will be presenting in the coming 10 minutes a topic about COVID-19 and the hypercoagulability. And I will give a brief background on the hypercoagulability in these patients and also short introduction about pulmonary embolism. And I will share some cases from our hospital and will include some references. Thrombotic complications in patients diagnosed with COVID-19 are emerging as important sequelae that contribute to significant morbidity and mortality. And the latest data suggests that the incidence can rise up to 50% in patients with COVID-19 admitted to the intensive care unit. The pathogenesis of hypercoagulability in patients is incompletely understood. The patients with COVID-19 have three underlying underlying factors that thought to contribute to thrombosis, including endothelial injury and stasis, and also hypercoagulable state. As regarding the endothelial injury, there is evidence of direct invasion to endothelial cells, as previous colleagues mentioned that the ACE2 receptors is attached to the virus, and then oxidative stress started leading to endothelial cell dysfunction, releasing von Willebrand factor, which starts the cascade of thrombosis. And also there is a number of changes in the circulating prothrombotic factors, including there is also significant higher amounts of or values of D-dimer, fibrin, fibrinogen degradation products, and also fibrinogen. There is also growing understanding that antiphospholipids may play a role in both arterial and venous infarcts. The thromboembolic events, either arterial or venous, can involve any organ from the head to toe in various frequency rates. However, the pulmonary embolism is the most common. It can be seen up to third of the cases admitted to the intensive care unit. Also, we can have DVT, acute limb ischemia, brain ischemic strokes, and also myocardial infarction. And the high rate of pulmonary embolism even can happen despite the absence of major predisposing factors. Pulmonary embolism usually seen in COVID patients, usually it tends to be peripheral in segmental and subsegmental branches rather than in the central lobar or main branches. And this is some references that you can check discussing this topic extensively. And other lung CT vascular parenchymal changes in COVID-19 can be seen in up to 89% of patients, including dilated subsegmental vessels and also vascular thickening and congestion, as well as a very interesting sign called vascular tree in bud, which indicates the thrombotic microangiopathy, which has been discussed previously in a paper discussing the thrombotic microangiopathy of that has been seen in pulmonary tumors. Looking into the histopathology in a patient died from COVID-19, we can notice this is the alveoli and this is the interalveolar septi. We can see in the capillaries the clots with in this area that the oxygen exchange happens, and this leads to what's called the happy or silent hypoxia. Patient is sitting beside you and he is hypoxic despite he's not dyspneic. And that's a very interesting finding. And this is a prestigious New England Journal of Medicine discussing the pulmonary endotheliitis and also thrombosis in these patients. We'll start with our cases. This is a 33-year-old male patient with COVID-19 presented with fever, worsening dyspnea and chest pain, and also high D-dimer, and the chest X-ray revealed bilateral lung infiltrates with peripheral predominance, as you can see in this area, and also CT pulmonary angio was requested to rule out a pulmonary embolism. And CT pulmonary embolism revealed multiple filling defects in the main branches of the pulmonary artery and as well as in the lobar and segmental branches. Looking into the lung window, you will notice that there is an extensive patchy consolidations and ground glass opacities. However, if we look into the map images, we will notice the interesting sign that's called vascular tree in bud, indicating the thrombotic microangiopathy. Usually the vessels in the secondary pulmonary dues are tapering smoothly. However, in our case, we will notice that there is a budding which is different from the tree in bud in small airway disease. This sign, you can see it through, it runs through the vascular tree itself. The other case with the 37-year-old female patient with COVID-19 admitted to the ICU with feverish, bilateral lung opacities, and severe hypoxia in this patient, high D-dimer, and also CT pulmonary angio requested to rule out pulmonary embolism and revealed the filling defects in the segmental and segmental branches. And also we have dilated pulmonary trunk indicating the pulmonary arterial hypertension. And also, in this case, we had the thrombotic microangiopathy by the vascular tree in bud. You can notice it here very clearly. And looking into the lung window of this patient, we have a mosaic pattern of appearance, which is indicating both in this patient the parenchymal ground glass from the COVID pneumonia itself, and also mosaic perfusion resulting from the pulmonary arterial hypertension due to looking at this lobular sparing. The other case with the 46-year-old male patient admitted with left-sided weakness. No other clinical data was given, and the patient labs has mild lymphopenia and high D-dimer, and CT brain was requested with IV contrast, revealing a filling defect in superior sagittal sinus, transverse sinus, extending into the sigmoid and also the proximal part of the internal jugular vein, denoting cerebral venous thrombosis. The upper cuts of the CT chest reveals peripheral ground glass opacities with posterior atelectatic bands, and COVID-19 was suggested, and results of the swab came as positive. And this is almost the same case, similar case published in American Journal of Neuroradiology, presenting the same exactly like our case. Another case with the 54-year-old male with a non-COVID patient. He has his chest X-ray revealed bilateral lung infiltrates, and CT brain was requested to rule out cerebrovascular stroke. And you can notice here the hyperdense basilar artery sign with extensive multiple infarctions involving the brainstem, cerebellum, and also the right thalamus, as well as the left side of the parietal region, parasagittal. And looking into the CT cerebral angiography, you will notice non-opacification of the distal part of the basilar artery, as well as the right posterior cerebral artery. The last case, a 21-year-old female patient, proved COVID-19 patient, presented with acute limb ischemia. CT angiography revealed occlusion of the distal part of the common femoral artery, as well as the proximal superficial femoral artery. And also the abdominal cuts revealed wedge-shaped renal hypodensity representing segmental renal infarction. Our key message is that COVID-19 is a serious contributor to hypercoagulation, which increased the fatality of the disease. Increased awareness of this potentially treatable complication of COVID-19 disease spectrum should be encouraged. Thank you very much.